Scenario 1. Gastric ulcer with massive upper gastrointestinal bleeding. A 58-year-old female was rushed to the emergency department following 3 bouts of hematemesis and a single bout of melena. On examination, she was tachycardic and hypotensive at 121 beats per minute and 90 over 50 mmHg respectively. She manifests pallor with no icteritis. She is eupenic and pneumothermic, but reports intermediate periumbilical tenderness. Medication history reveals occasional intake of non-steroidal anti-inflammatory drug naproxen 250 mg for arthritis management. On admission, her complete blood count revealed a hemoglobin level of 5.1 with a hematocrit of 32%, prolonged prothrombin time, and a positive block test. All other laboratory studies were within normal limits. Based on these clinical presentation, and intravenous fluids were administered and 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted, and an upper gastrointestinal endoscopy was performed, which revealed a 1 by 1 centimeter hemorrhagic gastric ulcer. The bleeding was cauterized. Biopsies were taken for Helicobacter pylori, the result of which are negative. Proton pump inhibitors were started, and she was discharged after 2 days in stable condition. In scenario 2, uncontrolled non-insulin dependent diabetes mellitus. A 58-year-old female with non-insulin dependent diabetes mellitus was seen in her primary care provider's office with reports of diminished sensation of both feet and occasional blurred vision. The client admits to problems adhering to her prescribed dietary and medication regimen. She does not exercise regularly, takes her medication only when reminded, and doesn't watch her diet. She denies dyspnea, polyphagia, polydipsia, and polyuria, and diaphoresis. The client has a history of non-insulin-dependent diabetes mellitus for 15 years and dyslipidemia and hypertension for 8 years. She has laser photocoagulation for retinopathy in the past year. She is on metformin and glipizide for controlled hypoglycemia, hydrochlorothiazide and aramapril, and antihypertensive and atorvastatin for hyperlipidemia. Upon examination, her blood pressure was 185 over 98 mmHg. Fasting glucose is 265 mg. Hemoglobin A1c is 9%. Serum blood urea nitrogen and creatine at 53 mg and 4.4 mg respectively. Urinalysis and 24-hour urine collection uncovered traces of protein and urinary albumin excretion rate at 255 mg daily, leading to a diagnosis of microalbuminuria. Nerve conduction studies and electromyography confirmed diabetic neuropathy, decreased visual acuity, and new extensive reticular vascular growth were revealed throughout the ophthalmologic exam. Based on the client's typical presentations, the final medical impressions of the diagnosis is uncontrolled insulin-dependent diabetes mellitus, complicated by hypertension, dyslipidemia, neuropathy, retinopathy, and microalbuminuria.